president and founder of the Occipital Neuralgia Foundation. So I've been dealing with occipital neuralgia myself for 6 years now. That's kind of what pushed me to create a foundation. And then Dr. Sheikh, so you're a board-certified neurologist, specialty in headache disorders. I was reading on your website, you have over 6 years of clinical experience treating complex headaches, and you take more of a holistic. Is that right?
Yes. So, so I did my headache fellowship in Boston, and I've been practicing for almost 7 years now since then. I have my own private practice in Chelsea, New York City, and most of my practice is headaches. That's what I specialize in. That's what I see 99% of the time. And and since I've started my practice, I think initially during our training, we learned about medications and procedures, but actually seeing a lot of patients and seeing what they prefer and what they want their approach to be, I've started to integrate a lot of holistic and complementary methods as well. So I do both. There's a combination. There's certainly medications that help, and in some instances, that's very important. But I do try to kind of do a holistic approach where you do lifestyle factor management as well. But sometimes you do need medications or injections that can be really helpful. So.
Right. Okay. Actually, do migraine stuff, right?
You're cutting in a little bit. Let me see if it's my phone. I'm sorry. You said.
So you deal with migraine yourself, right?
Yes. So I see all kinds of headaches. Migraine is so common that ends up being most of what I see. But I also see all other different types of headaches as well. But yeah, migraine is probably more than 90% of the headaches that patients present with. Yeah.
Okay.
Yeah.
So several people sent in questions regarding occipital neuralgia. I know you mentioned several people who have one. So can you just tell us what exactly is ON?
Yeah, so occipital neuralgia is a really interesting phenomena. We see it with a lot of different types of headache. You can see it in patients who have migraine or other types of headache, or you can see it on its own. And essentially, it refers to where someone is experiencing pain. So neuralgia means pain that is coming from the nerve, and occipital means it's the name of the nerve. So the occipital nerve comes off of the top of your spinal cord. It comes off of C1 and C2, and then it innervates the back of your scalp, but also the muscle that runs down your neck. And so all these patients, they have pain in that area. So it's usually in the back of the head. It can be on one side or both sides. And typically, sometimes it can also run down your neck and even down into your shoulders and upper back. So anywhere where that nerve has distribution and provides sensation, you can have pain in those areas. That nerve that comes off, I mean, there can be, tons of different reasons that nerve is activated or hypersensitive. It could be an issue with your vertebra or the nerves that come off of it. So there can be something there in the spinal cord or in the vertebra. But sometimes it can just be, we don't know the reason. It can happen without any, precipitating factors. Sometimes patients do describe that they had like a motor vehicle accident, they had some whiplash, but we don't always get that history. And it tends to overlap with migraine. So patients that have migraine, their nerves become hypersensitive, and the occipital nerve is one that is very commonly hypersensitive and activated in patients who have migraine. So they a lot of times will also describe that their pain, in addition to maybe being in the front of the head, is in the back of the head in that distribution. So sometimes it can be really hard to say, does someone have just occipital neuralgia, or do they have migraine that's now causing pain in that area? There's still a lot of research that needs to be done to kind of help delineate, is migraine and occipital neuralgia, run in the same family, or are they distinct entities? But we commonly see patients who have migraine have pain in that area, either just there or, in the front of the head and the rest of the head as well.
Okay. So from like a patient perspective, how like does the migraine pain, ON pain?
Um, so a lot of times patients with migraine describe their pain as throbbing or pulsating. Um,
Mm-hmm.
it can feel, sometimes they describe it as pressure. Um, if you particularly have the occipital nerve involved, and the occipital nerve, actually there's two branches to it, the lower branch and the greater branch. So if the occipital nerve is also involved, they can also describe that it feels like electrical shocks of pain or tingling sometimes, and particularly where the occipital nerve comes out from under the muscle and starts to innervate the skin, that part of the scalp can also feel very tender. So just by touching it,
Right.
it can feel very tender in those areas. So there's a little bit of a distinction between someone having migraine without occipital neuralgia, and then, or someone who has migraines, but then on top of that, that nerve is also very sensitive. So sometimes it's not easy to tease out, but if they're
Yeah.
describing like electrical shocks of pain, or a lot of tenderness and sensitivity to touch in those areas, then we start thinking about occipital neuralgia as well.
Okay. Um, so what would be worth treatment for us?
So for occipital neuralgia, I mean, if we think it's related to migraine, typically we'll start with treating the migraine and see if that also improves. But for patients who only have occipital neuralgia, or if the occipital neuralgia is a big component of their migraine, we can do several things. There's some medications like gabapentin that tend to help with nerve pain, but you can also do injections back here, because the
Right.
nerve is right under the skin. It's very easily accessible, and so we can do nerve blocks, which is giving a little bit of lidocaine or bupivacaine. These are all numbing agents, and we inject it around the nerve. And essentially, what we're trying to do is turn the nerve off and stop it from being so sensitive. Patients can get these every 3-4 weeks, and they might notice that over time it's more and more effective. Physical therapy can be really helpful, because a lot of what happens is once the nerve is irritated, then the muscle in the back of your neck and your shoulders also start to get really tight, and it turns into a cycle where the muscles are tight, so that's irritating the nerve, and then the nerve is tight, so that's causing more muscle spasm. So physical therapy can also be really, really helpful, and I suggest that, like neck stretching, yoga, or sometimes a referral to physical therapy, that can be very helpful as well. If those initial conservative measures don't work, there are surgeries that can be done, and there's two things that are really invasive. One is surgery, and I think someone is just actually asking about nerve decompression surgery. And then the other thing is placing a occipital nerve stimulator, where
Mm-hmm.
you actually put a little device under the skin in that area, and when patients are starting to have pain, they turn the device on, and that sends electrical stimulation to the nerve in a way to try to decrease how active it is. So those two things are pretty invasive. So it's important that you've tried some of the more conservative measures, because anytime
Mm-hmm.
you do surgery and you're cutting open the skin and then into the scalp, there's different risks that can happen,
Yeah.
infection, especially if you're leaving an occipital nerve stimulator under your skin. Sometimes the body can, react against it, because it is metal wires and things.
Yeah.
So typically we like to start with the occipital nerve blocks. Different medications like gabapentin or Lyrica might be helpful. Physical therapy is really, really helpful. And then if, those things haven't helped, then really the occipital neuralgia is very debilitating, then surgery or the nerve stimulator can be options. Yeah.
Okay. Now, like with the nerve block, that's something that you would need to go for. Like you go for several nerve blocks and eventually pain by.
So what I've noticed is that patients who have a clear trigger for their occipital neuralgia tend to do better with the nerve blocks over time. So I've had patients where their occipital neuralgia started after a motor vehicle accident where they had whiplash and their head was turned very quickly. They tend to do really well with the nerve blocks. They'll need them maybe 3-4 times over, like a 6-7 month period. And then over time, the nerve will also start to heal and they won't need them anymore.
Okay.
If we combine the nerve blocks with physical therapy, we tend to see that works better as well. So kind of addressing the muscle spasm and the muscle issues in addition to the nerve. But a lot of times these patients are patients that are going to be getting the nerve blocks, and it's not necessarily something that cures the occipital neuralgia, but really just keeps the pain under control. And it's a way to, lessen how much pain they're having. And the nerve blocks are very safe. I mean, it's lidocaine, it's right under your skin. Theoretically, there is a risk of infection or bleeding, but that's exceedingly rare. So it's something that they can have done. I have patients that come in monthly for their nerve blocks. And it's great because then they've been able to decrease how much pain medications they're using. And it really does give them some relief. So.
Yeah, that's important to reduce the amount of medication.
Yeah.
So let me see. Yeah. So as far as the ON pain is usually one-sided, both sides can shift.
Yeah. So with migraine, it tends to be bilateral because migraine is something that affects your whole brain. And if there's a trigger for it, like I mentioned, someone was lifting something and strained their neck, or in a car accident, it's typically one-sided. So it really depends. Is it primarily, an occipital neuralgia issue, or is it something, a part of something bigger? It can shift sides. What's interesting is some people who get a nerve block on one side notice that the pain shifts to the other side. They didn't necessarily have it on the other side before. And it's an interesting phenomena. We think that what's going on is that now one side is the nerve is quiet, so the other one becomes hyper. So then we will just start doing bilateral nerve blocks after that. But overall, it really depends on whether it's bilateral or unilateral, depending on the underlying cause or etiology of the occipital neuralgia.
Okay. Okay. Comments. My audio's breaking up.
Yeah, I can hear you okay for the most part, but it is breaking up a little bit.
Okay, let me go off my Wi-Fi.
Okay.
So now going back to the nerve blocks, I know there's doctors they do diagnostic nerve blocks, and that's kind of how they tell on how to go out. Talk a little bit about that.
Yeah, so if you don't respond to the nerve blocks, that doesn't necessarily mean that that's not what you have. But what can be helpful is to see if you do respond to them, then we know that the nerve is irritated. So it's diagnostic if it's helpful, if you've noticed that the nerve blocks do help. Sometimes, you also, as part of the workup for occipital neuralgia, you want to make sure that you've had, if it's something that's been ongoing for so long and you've tried different medications, you want to make sure that you do see a physician or a neurologist to get a good neurological exam, and make sure that the vertebrae or the discs in your neck are not the issue, are not pushing on your nerves, or there's not something else there that's irritating the nerve physically. So sometimes it can be helpful to also get imaging, but most of the time it's really based on your history and your exam to diagnose occipital neuralgia. Yeah.
Okay.
And because the occipital nerve blocks are so safe, we'll do them even if we're not sure that that's exactly what's going on. Because if you respond, then we have a better idea that, it likely is occipital neuralgia.
Okay. And then going back to, occipital neuralgia, migraine, do the medications that treat migraine